Okay, well, welcome guys. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to why. Because when you know why you do what you do, it changes the how, and that changes everything about the patient-oriented decisions that we all make, guys, every day. This topic review is focused on continuation of our evidence-based medicine series. It's going to be the third step or the third A of the 5 A's, and that is known as appraising the evidence. Again, while this topic might be able to stand alone on its own just in here and you're visiting, you should consider watching the other lectures before this. What is EBM? Step 1, or the first A, which is ask. The second step, which is to acquire the evidence, because it builds. And I'm going to continue to build on that here as we move through the 5 A's of evidence-based medicine. From a big view perspective, right? So we have best available evidence combined with our clinical expertise with the patient-specific factors. Again, together, when all of these are in balance, equally considered, we are truly implementing the process of evidence-based medicine. And remember, when we focus in on getting that evidence, then what is the best available evidence? There are 5 steps or 5 A's that we talk about a lot, or you'll hear about. Step 1 is ask the right clinical question with its core elements. That's our PICO or PCOTS, which I like to use. Number 2, or step 2, is to acquire the information. That's our search strategy, which was built on and influenced by the 4 elements of our clinical question. Once you've found the paper that seems to fit, i.e. the papers that you scanned, their PICO matches your PICO, then you have to read the paper. Not just read the abstract. We do not encourage, and I do not encourage, abstract medicine being practiced. i.e. you read the abstract and you think you are practicing evidence-based medicine. That is not the case. I don't mean to be rude, I don't mean disrespectful, but that's dangerous, right? Because people don't give all of the information or the context of the evidence in the abstract, and you might misrepresent the information or over-extrapolate it and think it's more valid than it really is. Our goal in the appraisal process is to look for evidence of bias, which does happen from time to time, looks for faults at some level in the studies, not because we want to pick things apart and be negative, but rather to determine how valid is this information and is the data and the outcomes believable. Because if they are, and it's internally valid, then I can externally apply it, which is step 5. Apply it to the patient care scenario that I'm in. And then the last one is assessing our own clinical practice, especially when you're implementing the same decision maybe more than once, because your patient population might be similar in the way it looks. You see the same type of patient, same demographics, those kind of things, same comorbidities. And so the application of a question or answer to a question might be able to be implemented across a larger group. Does it work? Does it align with the evidence that you see from the literature itself? Okay. Now, what is potentially wrong with the use and the word of critical appraisals? Because that's what we talk about are CATs, Critical Appraisal Tools. And I'm going to walk you through those here in just a minute. I have some nice tables that summarize these. They're great downloads for studying. They're also great for using as reference tools when you need them. They're also good for presentations. So if you need that, use it. We'll come to that here in just a second. But CATs, or Critical Appraisal Tools, can sometimes come across as being negative. And the reason that's negative is because we're seems to be critical about the paper. Listen, guys, there's no such thing as a perfect clinical trial that exists. It doesn't. So stop expecting the unrealistic of researchers who are doing research. It's a lot of work. If you've ever done a clinical trial, which I've done, and I participated in multi-centered clinical trials as a site investigator, my goodness, it's a lot of work. And we spend a lot of money, time, and effort trying to do the right thing, trying to get the right data that can be available for us. But the reality is, sometimes we have to make adjustments, or the type of study that we would like to do is not feasible. So it's not that researchers are looking to make a mistake or do less than desirable research. It is just the practical nature of doing research in a real-world environment where sometimes resources are limited. So be careful to not be negative. I actually, and when I was doing my training at Oxford, the faculty there really ingrained us more of like, it's not about being critical in the negative, but rather systematic. When you're systematic, that means what you're doing with these cats is that you're reproducing the same process of how you read a paper, what you're looking for, and the questions that you ask of yourself to determine, is there enough bias or concern here that challenges the internal validity of the results? Because if there is, and you identify it early, then stop reading the paper. It's a waste of your time. There's no point in further reading a paper that is internally invalid because you cannot externally apply it. But being systematic is what critical appraisal tools are really trying to do. And so I wanted to stress that terminology. While you may read about CATs, you hear the word critical appraisal tool, I want you to think systematic, reproducible, the same approach over and over. And the reason, if you do that over and over again, you are more likely to be able to assess the paper in balance, to be objective, and the interpretation of your assessment is going to be more valid itself, right? When you go in with a bias, or you're skipping all over the place and you're jumping just to the results and you haven't read anything else, you miss a part of the story, which is you want to apply it, but does it apply to your patient? Well, that goes back to the demographics, the inclusion-exclusion criteria. It goes back to the setting. It goes back to their outcome. When was the timing of their outcome versus your outcome or your PICO's outcome? All of these things determine your proper assessment of the paper and then, of course, its application. Okay, so what are some of these different tools? Well, I want to first address reporting guidelines, or what we would consider as publication guidelines. Those are slightly different than CATs, but it's important to talk about them because you might use a publication guideline or a reporting guideline or statement as a tool to make sure that the authors and the journal, if you will, are following accepted standards of publication practices. I.e., when you publish a randomized controlled trial, that trial has certain parts. It doesn't matter what journal you read it in. What you don't want to do, and what we all don't want to do, is have to pick up Journal A and read a trial that looks different than Journal B, that looks different than Journal C, and then you've got to try to find where's their stuff. If you remember, and most of you that have been scanning the literature, or at least aware of it, you've read clinical trials and the structure looks the same, especially in the last decade. And that's because of things like the CONSORT statement, which periodically they do go through updates, right? And so those are published and available, and journals, publishers, editors are supposed to follow these so that when you read one clinical trial in one journal, it looks and structured the same in another, so that we can read things even in different environments or different publications with a same degree of expectation of where we find information. If I want to know what statistical analysis it is, well, that's in the methodology section. Okay? So when you look at some of these things up here, you have, based on the publication type, guidelines, systematic reviews, randomized controlled trials. They each have some validated and structured or agreed upon statements or guidelines. And I've listed those there for you and then provided you with the known main web address there so that you can find those based on that. So when I read a paper, I want to know, did they write it right? Because that's, if they're sloppy, the journal's sloppy, the editors are sloppy, the authors are sloppy, well then the data could also be sloppy. And so this can be one way of appraising a good paper or identifying a well-written paper. But these are different from CATs, or Critical Appraisal Tools. Well, you can see, and those of you that are listening to us on the podcast, I know you can't see this, but what this table is, and for those of you that are looking at the video, I know it's small. So we have these tables available for you at thisiswhy.health. Just go there and go to the episode or topic. And if you don't have a membership or subscription to us, it's free, right? It's just access to things. We don't share your information, that kind of stuff. But it's free, but you get access to downloads like this, handouts that can serve as good study tools if you're studying for board exams, because some board exams like to ask these questions. It can be good if you're teaching this subject. Feel free to use it. We built it for you and to help people. I needed it. Other people need it. That's the goal, is to help each other out. But you can see it's rather busy. And so there's different guideline or different publication types, and then there's different critical appraisal tools or systematic appraisal tools. And then, of course, I provided the reference or citation or link to that group so that you could, go and find it yourself. And they, again, like I said, they update these periodically. But you can see almost every publication type, from guidelines, systematic reviews with a meta-analysis, have their own. CASP is one of the ones, CASP, C-A-S-P. They have one for randomized controlled trials that are being used, and then even a CASP for observational studies being used in a meta-analysis and systematic review. Systematic reviews only, that's AMSTAR 2. Randomized controlled trial, that's again CASP, C-A-S-P. Quasi-experimental, JBI is probably one of the best ones out there that's used. Real-world evidence, the Appraise tool is used. There are some other ones that are backup alternatives like GRACE. Okay, GRACE. Cohorts, Newcastle, Ottawa scale is also available for that, in addition to CASP. Case-controlled studies, again, CASP, Newcastle, Ottawa scale. Down in diagnostic studies, the QUADIS has gone through a number of variations. And so again, I think it's changed hands, who's going to be managing it and continuing to update it as it needs to be in history. So you might recognize that it's changed its location, but I give you the original source of it. And then, of course, there are qualitative economic evaluations and even clinical prediction rules. You'll notice that CASP, C-A-S-P, is fairly repetitive here. And if you go to that website, you'll see all their critical appraisal tools. And again, they're downloadable tools that you can use. Literally, it asks you questions, and you just fill in the blanks, or it forces you to go through that systematic process to determine if there's areas of bias. It's almost like trying to be very objective about it, which is good, right? It's what we should do. It's the appropriate thing to do. JBI also has a lot of CATs that are out there available. And then, of course, some of these other ones have some nuances that are validated in the literature. You can read more about those. I don't think it's necessary to go into all the details there. I wanted you to have access to the CATs, because when you read any one of these publication types, especially early on, in your training and understanding of EBM, it's important to establish that pattern, that systematic process for how to read a paper. Now, there are also the tools that are evolving that help us to assess the risk of bias, okay? And depending on the type of study that you're talking about, those that are randomized controlled trials, right, ROB2, non-randomized controlled trials that are going to be used, those that have exposures versus interventions, Robbins E, Robbins I. Those that maybe look for risk of bias due to missing evidence. That's an interesting perspective. And then there are even visual tools that many of you probably have seen or started to see more as you read papers. And that is a visual tool that allows us, based on each study that is being used or reviewed, that you give it or designate it a label. And this is obviously the traffic signal of green is safe to go through, yellow is like warning, red is like bad, stop. So, a high degree of bias are these red. So when you just step back and you look at this image, and if you were looking at a meta-analysis, systematic review of papers, and you were assessing all those papers for their risk of bias, you'd go, okay, I see some reds in here, but there certainly are more greens and less yellows than greens, and looks like maybe almost equal to or less than the yellows or the reds, right? So there's some high risk for bias papers included here. What does that then do to the internal validity of the meta-analysis or systematic review that's being done? And it's, again, you have to, at some level, as the reader, discern that for yourself. That's why we teach these principles of evidence-based medicine, so that you can be a lifelong learner who learns to apply the evidence appropriately to your patient population. That means you need to know how to interpret it. And if there's concerns enough in here for you that you don't believe that this data is internally valid because of the inclusion of these high risk for bias papers, well then don't read it, right? It's not going to be your paper. But a good author and group of authors doing something like this will do sensitivity analysis. What that means is they'll analyze their results with some of the papers that are maybe higher risk for bias to see what degree of influence are they having. What is it still doing to the results? What story is evolving when you add it or subtract it? Not because you're trying to hide it, but rather you're trying to see the degree of influence. Because we know that bad data can taint good data. It waters it down. So you might exclude that if it meets a certain criteria. Again, these are visuals that you'll see published in the literature that help us to navigate some of this, okay? All right, so the point here of, again, appraising the literature is to be systematic, not to be negative. There's no such thing as a perfect paper, right? So the point of this process is to go through the methodology. How are we going to read it? How are we going to interpret everything here? That's pretty straightforward. You just have to use the CAT. If you've never used one before, download it and use it through a paper. You might feel like this is dumb. I can't believe I'm doing this. I can't believe Dr. Busti said he did this. I'll admit I said that. When I actually said that, I was like, are you seriously asking me to fill in the blanks here like I'm back in elementary school, some scenario? And they were like, yeah. And I was like, okay. So I did it. And as I did it, there were questions in that systematic process that I was recognizing, I actually don't ask that question of myself, or I didn't stop to think about it like that. And then I began to respect, obviously, the process and why smart people use them and develop them to begin with, right? So trust me a little bit when I say to you, these exercises do have their merit. Now, do I still fill in the blanks of these papers? Download a CAT and actually fill it in? I do not. I did it enough to where, kind of like in our medical practice, when we do a SOAP note and we present a patient on rounds and we have our chief complaint, our history of present illness, the past medical history, surgical history, family history, social history, move on to objective, vital signs. I mean, that's a process, isn't it? It's just being systematic so that we don't miss key information that pertains to the things that influence our decisions about our patient. Same thing about this paper. So I hope that you found this to be useful, because guys, it really does transform the medical decisions that we make. And I hope that it made clarity there of a little bit of the why I spent so much time doing that. So we're going to move on to the next step. So please join us on step 4 and 5. If you have not watched the other steps, it's good to get that foundation so that we build a foundation that is integrated and solid. See you next time.